I'd like to introduce our next speaker who's going to do a computer switch on us here. This is the Mac PC world. You guys have seen all those ads on TV. We won't do a little Mac PC thing here.
I'm a Mac.
My husband, who's out there, will appreciate that. I live with a Mac guy, so I'm very sensitive to this issue. So Dr. Jeff Frasier, many of you know. Those of you who don't know him, he is actually behind the scenes in the care of your children at our facility. Jeff is one of our pediatric cardiologists who has a special interest in Kawasaki disease. He's our go-to guy for all of our children with aneurysms. And is involved with reading the echoes, interpreting the echoes, and is going to talk with you a little bit this morning about the heart in Kawasaki disease during the acute phase, and then we're going to have a break. We want you to write down your questions. We're going to have some runners, yes, going up and down the aisle collecting those. And then in the next session, we're going to address the issues of long-term complications of the heart. So Jeff is really talking about the heart during the acute phase and in children, and then we'll have our adult cardiologist after the break. Thank you, Jeff.
Okay, does this work? Great. Okay, can you, no? Maybe I'll just hold it. All right, well, thank you for that introduction, Jane, and thank you all for coming to this. I really applaud you. I think that it really says a lot about your commitment to this disease and your children to take time out of your Saturday morning to come to a conference. I also want to thank Jane for inviting me to give this talk, and I think you know, we don't get a lot of opportunities to publicly thank our coworkers, and I just want to publicly thank Jane for all that she does. She's really an example of an excellent clinician that is really dedicated to her patients, and an excellent researcher, and an excellent person. And so I just want to say thank you, Jane, publicly. For everything that Jane does. All right, well, so when I started thinking about what I wanted to talk about today, I tried to put myself in your shoes and think about what is it like when you find out that your child is going to have Kawasaki's disease. I think maybe it's something like this. If you're not screaming at us externally, you certainly might be screaming at us on the inside. It also might be something like this, feel something like this. Ouch. Yeah, maybe, I don't know. And little did you know, but you were taking a dive into the deep end with us, and that dive is not always perfectly smooth. Ouch, again, right? Okay. And you're going for a long adventure together with us. Yeah. So I often tell my families that you know, once you have Kawasaki's disease, you're kind of in the family again. It's like the mob. You know, once you're in, you're in. So welcome, brothers and sisters, I guess, huh? And so from my side of things, when I walk into a room to see a family with Kawasaki's disease, I'm always thinking that, you know, I think of this cartoon. This is from the far side. This is a Gary Larson cartoon. And the top pane there, for those of you that can't read it, says, what we say to dogs. It says, okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger? Stay out of the garbage or else. And the bottom pane says, what dog's here? Blah, 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 Ginger, blah, 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 Ginger, blah, blah, blah. And I think maybe when we come into the room and talk to you about Kawasaki's disease and how it can affect the heart, I think you guys might hear blah, 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 heart, blah, 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 coronary arteries, and that can be kind of scary. And so I want to try and demystify the heart for you a little bit today, and hopefully give you some perspective on things. And what I'm going to really concentrate on, there's a multitude of things you can talk about related to the heart and Kawasaki's disease, and I'm going to really just concentrate on the coronary arteries and talk a little bit about the long-term recommendations and our long-term follow-up that we do in the pediatric cardiology clinic. So I'm going to briefly talk about what the coronary arteries are, what their anatomy is, and how they work, and then how they're affected in Kawasaki's disease. All right, so what the heck are these coronary arteries? So these are blood vessels that rise off of the aorta, and I know this, a lot of you know this, but just to make sure we're all on the same page here. These are blood vessels that arise off of the aorta, and their job is to supply blood to the heart. So when our heart pumps blood, it goes out to the tissue. The tissue takes the oxygen out of the blood and gives up the stuff that it doesn't need, the carbon dioxide, and that's exactly what the coronary arteries do, except they supply the heart. So obviously that's very important. If there's some compromise of blood flow into the heart, there can be problems getting, having the heart work well. So, and there's anatomy. I'm going to show you a picture in a second, but there's a right and a left coronary artery. The right coronary artery supplies, as you'd expect, the right side of the heart, and the right side of the heart pumps the blood out to the lungs, and the left coronary artery supplies the left side of the heart, and that side's responsible for pumping blood out to the body. So here's a little diagram. And I use this because I wanted to feel a little bit like Vanna White, so here, without the evening dress. So anyway, these are the coronary arteries. This is the right coronary artery here, and this is the left coronary artery. The left coronary artery splits into an artery called the left circumflex coronary artery that goes around the back of the heart, and then the left anterior descending coronary artery. And these little branches here, all of these branch off into smaller branches and smaller branches until there is a place where the oxygen can be exchanged at the capillary level. This is a little animation of sort of, oops. This is a little animation of sort of what I just talked about, and there you can see the right and the left coronary arteries with the heart intact. The pulmonary artery is sitting right here, and this is the aorta. And if I let this play a little bit more, they'll take away the rest of the heart, and there's the coronary arteries being attached to the aorta. Okay? Now, when the heart is pumping, oh, here we go, blood gets pumped out of the heart into the aorta, and then blood flows into the coronary arteries to supply the heart muscle. So how does Kawasaki's disease affect the coronary arteries? Well, there's sort of acute effects that include dilation and aneurysm formation, among other things, and then there's longer-term effects, and touch a little bit on both of those things. So this is another animation. This is an animation that Jane put together with the Kawasaki's Foundation, and you're going to see the heart beating here, and we're going to start out by looking at a coronary artery that is going to look a little inflamed. Okay, and we're going to actually go inside that coronary artery. Inside the coronary artery, you can see that there's red blood cells and white blood cells, and then there's this layer down here that is the endothelium. So this is the wall of the blood vessel, and this should be sort of a barrier to the blood leaking out of the wall. But in Kawasaki's disease, there's some stimuli that causes the endothelium to allow white blood cells to cross the endothelial layer into the wall of the blood vessel. And these white blood cells come into the blood vessel, and then they release mediators, including TNF-alpha that you just heard about, and many others. And these mediators sort of ramp up the inflammatory response in the wall of the blood vessel. And that inflammatory response can damage the blood vessel and can cause increasing fibrosis and other changes to the blood vessel. Those changes can cause the blood vessel to become somewhat weaker, and it can dilate, and this blood vessel is a little bit dilated when you compare it to the blood vessels on the side here. Okay. Now, giving IVIG before 10 days of the onset of fever can prevent this, but not exclusively. And we have many patients, unfortunately, that receive IVIG in a timely fashion and still have dilation of the coronary arteries. Now, if it's just dilation, a lot of times that dilation goes away and the coronary artery kind of goes back to normal again. But in a certain subset of patients, the coronary artery becomes aneurysmal, and this is an example of an aneurysm. And here you can see the coronary artery sort of balloons out and gets very, very dilated. Now we're going to look at the internal flow of the coronary artery. So here you can see this is the lumen on the inside of the coronary artery and the blood flow of the blood through the coronary artery. And this is an example of an aneurysm. Okay? And what you're going to see here is that the blood, when it's flowing normally, it kind of flows in a uniform fashion. All the blood is moving at the same speed. However, when there is an aneurysm, you'll see these little eddies or swirls as I let this play here. And those are sort of non-uniform flow of blood. And that can predispose you to thrombosis and clot formation. And here you're going to see over here a clot is going to form. And this is how you can get a clot or a thrombus or get a heart attack in the early part of the disease. Then there are chronic changes that occur with the coronary artery. So you'll see that the blood flow now is going in this direction. There's still some eddies. And then there's some fibrosis that starts to occur. And that fibrosis causes is done so that is produced by the body so that the blood flow goes back to kind of how it should be. So the coronary artery sort of straightens itself out again. Okay, so that seems like a good thing, right? But too much of a good thing can be a bad thing, and that is what can happen late in Kawasaki's disease, is that this fibrous tissue can kind of start to stick out into the lumen of the blood vessel, narrow the blood vessel, and lead to a heart attack later. So just to recap all that, so there's some inflammation that occurs in the coronary artery wall that leads to damage of the coronary artery wall. That can lead to dilation or aneurysm formation. In the acute phase or the early phase of the illness, that can lead to thrombus or clot formation, and later it can lead to some fibrosis. I'm just going to briefly talk about cardiac echocardiogram because I know Dr. Khan is going to talk about that a little bit more. The reason we use cardiac echocardiograms to diagnose this and then follow the coronary arteries are several-fold. One is that it's non-invasive. Back in the old days, the only way to look at probably, I was about 5 when this was happening, but 5 years old, but was to do a heart catheterization. And we still do heart catheterizations on an infrequent basis, but ultrasound is completely non-invasive. We don't have to put any catheters into the body or into the heart. Echocardiograms are safe. There's really no radiation. Your child, if they're of a certain age, will need to be sedated, of course, as you all know. To get good images, but there's, aside from the risks with sedation, there's really no safety concerns with an echocardiogram. And it has a high sensitivity and specificity, which is just a fancy way to say that it's a good test. Okay, so it's a relatively accurate test. And it's reproducible, so we're able to do an ultrasound one day and then do another ultrasound a month later and compare the two and say, okay, this coronary artery looks like it's getting bigger, it's getting smaller, it's the same size. And I'm just going to do show a couple images of echocardiograms here. So this is the heart muscle here. This is the right ventricle, the left ventricle, and this is the aorta. And so we can assess how well the heart is squeezing and take a look at the size of the different heart structures. This is an ultrasound showing the aorta, which is over here, kind of half of the aorta. And this is the left coronary artery. There's the left main coronary artery. I think I have a still frame after this, yeah. So here's the left main coronary artery. It splits into the left anterior descending coronary artery and the left circumflex coronary artery. And this is, you've all seen a ton of these, I know, but this is where we make our measurements and kind of decide whether we're seeing something that is significant or not. And when we make those measurements, we compare them in your child to other children that have the same body size and height. Now this is an example of a patient that has aneurysms. So here you can see the aorta, and here you can see the left main coronary artery, and here you can see the left anterior descending coronary artery. It's very big, almost the size of the aorta. And here they are sort of in side by side. So here is the aorta in this patient with the dilation, and here's the normal. So you can see the striking difference. Now these are giant aneurysms. This is a very, very big aneurysm. This is not every patient. Okay, so due to time constraints, I'm not going to talk about some of these other things. For example, the effects that Kawasaki's disease has on the heart muscle. And there's very good evidence that there is some inflammation in the heart muscle during the illness. And there's also some effects on the aorta. The aorta can become dilated. So I'm going to just talk, you're going to have another talk about long-term follow-up of Kawasaki's disease. So I'm going to just sort of talk briefly about one specific point on that. So coronary artery lesions regress with time in some patients. That's about 50% of aneurysms. Dilation regresses more frequently. There's some things that can make you more or less likely to have your aneurysms or dilation regress. The original size of the aneurysm, the younger the child, the lesions are more likely to regress, and there's certain anatomic types of dilation that make them more likely to regress. So what kinds of things do we think about long term? So are the coronary arteries normal, even if they've regressed to normal size? And we have Dr. Burns and her research group working on ways to kind of figure out whether this is going to be true or not. Is there dilation of the aorta, and what kind of clinical significance does this have? What significance does the myocarditis have on the long-term function of the heart? And we really encourage maintenance of a healthy lifestyle and diet, and occasionally get laboratory monitoring of their lipid status and cholesterol levels. Okay, so in 2005, Dr. Burns and Dr. Takahashi, who's here somewhere, and a bunch of other smart people got together and through the American Heart Association and discussed kind of what kind of risk levels do different patients have for coronary artery disease later in life and problems after having Kawasaki's disease. And they split them up into 4 risk levels, 1, 2, 3, and 4, and we're just going to go through those individually now. The purpose of this risk stratification was to discuss what kind of physical activity can they do, what are some medications that will reduce the risk of, what medications do you need to reduce the risk of thrombosis in high-risk patients, how frequent do you need follow-up appointments and tests, and how often do you need advanced imaging of the coronaries. So risk level 1 patients are patients that have no coronary artery changes at any stage of the illness, and meaning that we do an echocardiogram, the coronaries measure normal for that patient's body surface area or their size, and then we repeat the echo and they continue to look normal on every echo. So in that group, there's currently no long-term anticoagulation meds that are recommended. There's no restriction of any physical activity after you're out of the acute illness, the first 6 to 8 weeks or so. We recommend periodic assessment and counseling of cardiovascular risk factors. And this is something that's a little bit new and in evolution, but since we're finding some of these other abnormalities with the heart muscle and with the aorta, we don't know the significance of those. We're telling all of our patients, even the ones that never had dilation or aneurysm, that they probably need to be seen every 5 years. And we don't recommend any advanced imaging of the coronary arteries, meaning CT scan, catheterization, MRI, etc. Risk level 2 patients are patients with transient ectasia or dilatation that resolves within 6 to 8 weeks. This group, this essentially you had some dilation of the coronary artery, you did not have an aneurysm, just it was dilated, and then it resolved after 6 to 8 weeks and went back to normal size. So in this group of patients, no anticoagulation is recommended after you're out of the acute illness. There's no restriction on physical activity, and we recommend risk assessment and counseling every 3 to 5 years for the same reasons that I just discussed. And that, for us, will include an EKG and an echocardiogram at a minimum. And again, this is an evolution, what kind of follow-up patients with Kawasaki's disease are going to need. And we don't recommend advanced imaging of the coronaries. So risk level 3, these are patients that have had small to medium-sized aneurysms, and those are aneurysms that have an absolute measurement of 3 to 6 millimeters, or have a, what we say a Z-score, which is the number of standard deviations above the mean between 3 and 7. And so in these patients, we recommend aspirin as anticoagulation to prevent clot formation until the aneurysms regress, or if the aneurysms don't regress, perhaps lifelong. Physical activity without restrictions until at least the teenage years, and I'll talk about that a little bit in another slide here. We recommend annual follow-up with a pediatric cardiologist or a Kawasaki's disease specialist, and if there's any of the testing that we do on these patients that's abnormal, then we recommend advanced imaging. So physical activity in patients with risk level 3, the recommendation is to avoid competitive high impact or contact sports in patients on antiplatelet therapy. That is partly due to the bleeding and partly due to the risk of coronary artery narrowing in these patients. This is sort of a recommendation, and not every patient follows this. They recognize that they might have an increased risk of something happening if they participate in these sports, but they're willing to accept that slight increase in risk. We recommend evaluation of the coronary perfusion during exercise. They get yearly EKGs and chest x-rays, and these are good tests, but it doesn't really tell us what's happening when the heart has to work hard. So what's happening when the patient is exercising, and what's happening when the patient is really putting stress on their heart. So these patients all get stress tests, and we're starting more and more to do myocardial perfusion testing to see how well the coronary arteries are supplied. Follow-up appointments occur yearly with an echo and an ECG, an electrocardiogram, and then probably every 2 years, at least after age 10 and maybe age 12 or so, an exercise stress test and one of these perfusion scans. And then if any of the above are abnormal, they get advanced imaging of the coronaries. And then risk level 4 are patients that, I didn't put that on there, but these are patients that have large aneurysms greater than 6 millimeters, and they do deserve long-term anticoagulation. This kind of historical medicine is warfarin. In little babies, that's a difficult medicine to titrate. It involves, as many of you know, monthly blood draws. There are some people that will use other medicines that include, this is Lovenox, low molecular weight heparin. This is Plavix, clopidogrel, and aspirin. And this is a little bit in evolution, but certainly the classic is using warfarin, and we'll see down the road if some of these other medicines are also going to be recommended or as efficacious as effective. Physical activity, we recommend no contact or high impact sports, but we do recommend recreational or dynamic sports pending testing, meaning if all the testing looks good, we do want your kids to be active. So we don't want them kind of sitting on the couch and getting overweight, because that's not going to be good for their coronary arteries. So we want them to be active and participating in activities. We recommend follow-up every 6 to 12 months. And these patients do get advanced imaging of the coronaries, and Dr. Khan's going to talk about that a little bit later. And in adult and teenage girls, reproductive counseling, there is a risk with pregnancy. And it doesn't matter your risk level, and really, if you don't have Kawasaki's disease, we recommend these things as well, but I think it's even more important in patients that do have Kawasaki's disease. We recommend a healthy diet, a healthy lifestyle, and laboratory monitoring of lipid status on a variable basis, depending on what your risk is and what your lipid status is, okay? Because we want those coronary arteries to be good for as long as they can be. All right, so the effects of Kawasaki's disease on the coronary arteries during the acute phase of the illness are, we kind of discussed that, and the assessment of the coronary arteries, I want to make sure that you guys understood the anatomy and the function, and talk a little bit about the risk stratification. And thank you very much.